This video covers the clinical protocol for handling patients who are dead on arrival, including recognition, resuscitation decisions, pronouncement, and communication. Our roadmap is organized into 3 parts: recognition and decision-making, procedures after the decision, and finally, a synthesis using a master decision algorithm. Part 1 focuses on recognition and decision-making, covering the critical steps from when a patient arrives at the door until the decision to terminate is made. To ensure effective teamwork, we must use shared language. This protocol clearly defines terms like brought in dead, DOA, death in the ED, and the rules for termination or withholding. Certain findings like rigor mortis, decomposition, or massive truncal destruction serve as unequivocal evidence of death, at which point resuscitation should not be initiated. Be careful not to extrapolate findings. Vague terms like clearly dead are not acceptable. Documentation must be precise, objective, and include the exact time and rationale. For initial assessment, confirm the arrest by verifying the absence of a central pulse and spontaneous respirations, followed by rhythm strips and a POCUS cardiac view. While performing these assessments, gather history in parallel from EMS or bystanders, and consider critical patient factors such as DNR status or potential toxic ingestions. Unless an obvious death finding or a validated rule applies, the default is to begin or continue high-quality resuscitation without delay. The AHA provides specific termination of resuscitation rules for both BLS and ALS settings, defining the criteria to consider when termination may be appropriate. This flowchart outlines the decision process in the ED. If a reversible cause is suspected, treat and extend. If not, consider termination after meeting the standard criteria. Before finalizing a termination decision, confirm that the resuscitation effort was adequate. Consider the ETCO2 trend, verify DNR/pulse documents, and consult the attending. Traumatic cardiac arrest requires distinct criteria governed by NAEMSP and ACS-GOT, taking into account the mechanism and specific findings on scene or in the ED. Do not withhold or terminate if signs of life were recent or a reversible cause is suspected. Such decisions must be made by the most senior clinician. Finally, when considering an ED thoracotomy, evaluate the specific clinical context, as outcomes vary significantly between blunt and penetrating trauma scenarios. When addressing reversible causes, remember the classic H's and T's. From hypovolemia and hypoxia to cardiac tamponade and toxins, identifying and treating these underlying conditions is vital. Certain situations, like hypothermic arrest, drowning, or pregnancy, may require extending the resuscitation threshold. Always prioritize core rewarming or specific interventions as indicated by the patient's condition. Moving to part 2 of our protocol, we will discuss the steps to take after the decision to terminate has been made, focusing on formal pronouncement and legal duties. When pronouncing death, ensure you have the authority to do so per your local regulations. Confirm the clinical findings, including the absence of pulses, respiratory effort, and heart sounds. Document your findings thoroughly. This must include the time, all interventions performed, rhythm observations, the rationale for termination, and the name of the physician making the pronouncement. In medico-legal cases, you must notify the medical examiner or coroner. This generally applies to traumatic, sudden, or unexplained deaths, or those occurring in custody. Always preserve forensic evidence by keeping lines and tubes in place. Furthermore, remember that organ procurement organization notification is a mandatory step for all deaths. Communicating with family is a core skill. Use the grieve_ing framework to structure your conversation, ensuring you provide clear, compassionate, and consistent information. Your delivery matters. Sit down, use clear and direct language, and allow space for the family to process the news without feeling rushed to fill the silence. Now we reach part 3, synthesis. We will look at a master decision algorithm that consolidates these steps into a single, manageable pathway for the resuscitation bay. This algorithm guides you from initial patient assessment to decision-making, considering medical versus traumatic etiology, special circumstances, and the final steps of termination and communication. To wrap up, remember that every termination decision requires careful confirmation by the attending. Thank you for your commitment to excellence in these difficult clinical scenarios.